We are healthcare providers, but we are also human beings. I hate to break it to you. We're not robots. And so we also have our own trauma experiences that we bring with us to work with our patients, with our clients. We have our own losses that we experience that we bring to our work, whether we want to admit it or not. We do. So I just want to sort of say, as we start to talk about some of these things, uh, do what you need to do to feel safe. If this feels overwhelming, if it's bringing something up for you, take the time that you need to process that. Um, and I just sort of want to acknowledge that because I think so often we get into this mindset of I'm a professional and so I should have these very, very strong boundaries, which is good. We do want to have strong boundaries. And we also have our own thoughts and emotions that we do carry with us throughout the day. So having that self-awareness, having to some time to think about that and process that before we actually go into situations that might trigger some of those can be really helpful. So I just wanted to sort of say that. So one of the things about Providence is we start all of our meetings with reflection or sort of basically the thought of how do we sort of center ourselves on what we're going to be talking about. So I wanted to start with this reflection. It's a poem called Anxiety and Trauma by Elizabeth Zink. So once were two young maidens who both wore smiles, but they were sadly separated. Years later, they became friends once again, but life had shaped their names. Anxiety and trauma both very much alike. Anxiety bit her nails, and trauma did as well. Trauma rocked back and forth, and anxiety did too. Over time, they both dropped subtle hints saying they were not okay. Anxiety went to therapy, and so did trauma. Trauma had a breakdown, anxiety also did. The difference lay within their fears. And so very terrified of the future, anxiety began. You get it though, right? Trauma shrugged. I guess I do. She paused. But it's the past that makes me break. The two girls looked at each other, realizing they knew nothing about one another. So I just like the idea of thinking about all the different ways that trauma can sort of express itself, and oftentimes anxiety is one of those symptoms, but it goes a whole lot deeper than that. So as we start to talk about trauma-informed care, talk about um, grief and loss as well, how do we sort of look at them and also separate them as well? So there's differences between trauma, there's differences between grief and loss, anxiety, all of those things. They're sometimes intertwined, sometimes separate, all sort of impacting one another. So that is our thought. So potential trauma events. So what do you think? So this is going to be interactive, by the way. So if you've got some sort of like fun music playing in the background, you might want to pause it before you answer a question. Got some Ariana Grande playing. Um, what are some potential trauma events that you are aware of or that you've seen or that you can think of?
Oh, like admissions to uh, like for medical related issues, if they have like a, I don't know, sepsis sort of thing, or maybe they get into a car accident and they're admitted and they have to do all the procedures sort of thing.
Hmm. Yeah. And that's going to be traumatic for the patient, but also for the family, right? Yep. What else? What are some other traumatic?
Unexpected death of a loved one.
Yes, absolutely. Or sometimes expected death. Let's see, I think there's some chats in here. Uh, car accident, survivor's guilt. Yep.
Abuse.
Abuse. Yep. Rape or assault. Absolutely. Hmm. Isn't this a lovely conversation for a Tuesday afternoon? Hearing others when intubated. Yes. There's a lot of trauma in healthcare that we don't really necessarily recognize. Um, so yeah, definitely. Just intubation in and of itself freaks me out. Anything else that you got?
When, you know, the memory cells and a baby that had a traumatic entrance into the world,
Mm-hmm.
I don't know, maybe that's going a bit off, but that that subconscious trauma.
Yeah, absolutely. Yeah. And memories are very weird things, right? How do we sort of suppress them? What does that look like? Can we suppress them? And then also, as somebody ages and they begin to potentially have some cognitive changes. So, if we look at folks who have dementia, all of those sort of things that they put in place to sort of protect themselves from traumatic memories are starting to break away. And so you have these folks who may have had a traumatic event and nobody knows about it. You know, in the 1940s, 50s, if sexual assault happened to you, oftentimes people didn't talk about it. There was potentially a lot of blame, a lot of self blame. And so as folks begin to enter into that dementia phase, they may not be able to obviously verbalize what happened to them. The family may not even know. It may start to come out with combative behavior during personal care, all of these sorts of things, right? So it becomes very complicated. Um, so Valerie says, losing a patient, absolutely. Yes, and it's great to sort of think about, you know, we think about our patients having trauma experiences, but we also have trauma experiences as healthcare professionals as well, for sure. Um, so again, recognizing that. Yeah.
Also, political climate and systemic racism. That's a huge one.
Huge. Yep.
Yeah.
Absolutely. Yeah. So yeah, as we think about some of these things, um, just mention some of these things. Not yet. So often what we think of is sort of that sexual or physical assault. Oftentimes we think a lot about veterans who've had a military experience, or refugees who are coming to flee a country where there is political unrest or even genocide going on. Prison sounds pretty traumatic to me. I've seen all seasons of Oz, and I can't say that I would like to go to prison. Um, Mental illness, right? And all of these things have a little piece of potential oppression or um, societal fear around them as well of how do I, as somebody who might have a diagnosis of mental illness, be perceived by people in society or by my healthcare providers, right? That sort of ongoing fear of how much do I share? How much can I sort of share and feel safe? Uh, um, and then when you look at gender or non-binary or anything like that, folks who are transgender, there's a lot of fear in the healthcare system, right? As folks who come into the healthcare system thinking, how much do I have to say? How am I going to be treated? That sort of thing. So there's actually a video, and I will send, actually at the end of this, I put the link in there. There's a video that was done by the Oregonian in Portland uh, that interviewed folks who identify as transgender. and their experience with the healthcare system, and it's pretty powerful. It's not very long, but it's just interesting to sort of hear sort of people's experience of not wanting to go to the ER because they're afraid of what might be said or not said to them, that sort of thing. So, but yeah, political, cultural, all of this sort of things, and then witnessing events, as was mentioned, as well. So a lot of things can cause some trauma and trauma experience. So symptoms of trauma response, and forgive me if this is a review for some of you, but these are some of the things that you might see in somebody or even in yourself. We'll talk a little bit more about that down the road. But numbness or detachment, anger, sadness, anxiety, feeling out of control, depression, shame, guilt. And then some physical symptoms, like sleep disturbances, high startle response, fatigue, flashback, and then also that spiritual pain as well. So when we talk about healthcare, we talk about sort of seeing somebody as a whole person. Particularly in hospice, we talk a lot about that, right? So not just the physical, but also the emotional and the spiritual as well, because they are all interconnected. So how do you, as nurses, actually incorporate or use your team when you need to? So is there a spiritual crisis going on? What are some things that you might hear? What are some things you might hear if you think somebody's having a spiritual crisis or existential crisis? What are some indications that you might want to involve chaplaincy or spiritual care?
Do you mean like when we hear, well, like I've heard people say many times, God's punishing me, kind of a thing?
Yep, absolutely. Yep. Yeah. What did I do wrong? God's punishing me. Yep. Sorry, my mouse pad is very sensitive as well. Yeah. Regret, guilt, that sort of thing. Those are some indications that might be some spiritual pain going on. Yeah. So all of these might be fearing that they won't go to heaven. They don't feel that they were good enough. Yep, absolutely. Thank you, Mariah. So we look at all these different senses that somebody might have impact around trauma. So the sight, sound, taste, smell, touch, all of those might trigger a trauma response. Right? So we never exactly know. So we want to be aware if we start seeing some of these symptoms right here on the screen, how am I going to modify my practice potentially? Do I need to move more slowly? Do I need to ask permission before I touch? Do I have to narrate my care as I'm going through my care of, now we're going to do this, now we're going to do this, all these sorts of things. What's going on in the room? How many sounds are happening? Can we mute some of these sounds? Can we reduce some of the light coming in? All of those might be impacting somebody's experience. So it's interesting. I like to tell the story of this gentleman who was living in a nursing home, and the nursing home was like every day at about 6 o'clock, he would just start ramping up, and he would become very agitated, combative, and it was always the same time of day, and they were trying all of these medications and nothing was working, and they were just like, what's happening, and that sort of thing. And finally it was, okay, let's actually look at his surroundings as well as what's going on. So what they realized was at 6 o'clock, that was change of shift for this facility, and his room had the window that faced the parking lot. So as all of the new staff was coming in at change of shift at around that time, all of their headlights were beaming right into his room. And he was starting to have flashbacks of wartime. So that flashing lights and that sort of thing, and the sound of motors, and it was triggering his trauma that he had experienced in wartime. They moved him to a different room, and he was totally fine. Right. So again, it's sometimes, and families will do this too. Families do this all the time in hospice. Um, well, what meds can we give him? What can what's sort of the magic pill or the magic medication? And sometimes there is, and sometimes there's not. And then we have to sort of think more broadly of what can we do to reduce um, whatever sensation is causing this response. So starting to sort of think about that can be really, really helpful and beneficial. So trauma is pretty prevalent. Again, oftentimes when we hear the word or the phrase PTSD or the words post-traumatic stress disorder, we do think a lot about our veterans, and that is a very valid concern, right? But if you actually look at statistics, so 70% of adults in the US have experienced some type of traumatic event at least once in their lives. Estimated 8% of Americans have PTSD at any given time. That's the total population of Texas. Right? So when we think about trauma and when we think about PTSD, they are very different, right? You could have experienced a traumatic event that's impacting your life. It doesn't mean you're going to get a diagnosis of PTSD, right? So there's all these sorts of things that have to be in place to get that diagnosis of PTSD. Time frames and responses, and you have to have two of this and one of this and that, stuff. So you can actually read about that if you'd like to in the DSM. Super exciting reading, I know. But that doesn't mean that people who have had this trauma over here aren't still experiencing stress and symptoms from that. So sort of thinking about the difference between trauma-informed care and PTSD, so sort of making that distinction. But also, if you look at the statistics, so an estimated 1 out of every 9 women develops PTSD, making them about twice as likely as men. So why do we think that that's the case? Why are women more likely than men to develop or have experienced trauma?
Perhaps that women went through the trials and the studies and wanted to be willing to have a diagnosis, maybe?
That's very possible. Women may be more likely to seek out help. Chelsea says more vulnerable. Jay says men are less likely to report. Absolutely. What else do you think might be going on for women in our culture and society? Are less systemic barriers culturally for men versus women, i.e. culturally impairing sexism? Yeah, yeah. So there's a large amount of sexism in our culture, and as much as we sort of talk about it, there is still a level there. Sexual assault obviously is also more highly prevalent for females than for males. So just statistically, it's interesting to sort of think about that. Also less socially acceptable for men to express emotions. Yeah, exactly. Yeah, all of these different things can impact the data that's out there. So this is very, very basic. Obviously, there's a ton of information out there about trauma-informed care, but so for key elements or the 4 R's of trauma-informed care. And all of this is from, you can see down there below, potentially it might be a little bit tiny, but from SAMHSA. So there's a link to this also at the end of this presentation too. So they have a ton of stuff on trauma-informed care. The other thing to understand is that trauma-informed care as a concept, or kind of using that phrase, is fairly new. And actually last year, the nursing homes had a new regulation put forth by Medicare saying that they had to have a trauma-informed care program at their nursing facility site, both for patients and for staff as well. So, and that had to be effective November of 2019, so last year. So you can imagine the nursing homes were freaking out about this, like, how do we do this? How do we do this? So there's a lot of information out there. But well, it's like, okay, if it's coming for the nursing homes, it's going to be coming for home health, and it's going to be coming for hospice, and it's going to be coming for acute care. So I think this is something that we're going to start hearing more about, which I think is a good thing. But it is something that people are starting to sort of talk about. So the 4 R's, so realizing the prevalence of trauma, we sort of talked about that. Recognizing how trauma affects individuals, the organization, but also systems and that sort of thing. So all of the different levels that it affects. Responding by putting knowledge into practice. So how do we then change again our practice of how we provide care to people? And then how do we resist re-traumatization? So some things to keep in mind when talking about trauma. A lot of times there is a feeling of having done something wrong, or there's something wrong with you, or there might be some shame of, well, you just need to get over this. You know, why are you still thinking about this? Why can't you sort of, other people are fine with this, why aren't you? That sort of thing. So rather than using the words wrong, or what, you know, what's wrong with you, changing that and reframing that to what happened to you. Right? So again, sometimes the words that we use can be very powerful. And not just in this instance, and any time that we use words, sometimes we use words that make sense to us as healthcare providers, but don't make sense to our patients or family members. For example, we had a patient at University of Washington Medical Center, and she was actually on the list for a lung transplant. She had very progressed pulmonary fibrosis, and she was about in her early 70s, and she was in the hospital for a while and finally got her to the point where she could go to a subacute unit. She didn't do well there and came back into the hospital, and there was this big care conference, and there was all, you know, the hospital, so there were the residents, the interns, the specialists, everybody was in that room. And they said, well, you know, you could do two things, right? We could make you comfortable. You know, we could focus on comfort, or we can still wait for this lung transplant. And so she's like, oh, well, I would like to be comfortable. So like, oh, okay, well then we will stop doing all this. We'll take you off the transplant list. And she's like, no. I want to wait for that. I'm like, oh, okay, well then. And they were very confused. And I was like, she doesn't understand when you use the word comfort care, that's an order set, right? That's a hospital terminology. She wants to breathe while she's waiting for her lung transplant. That's what she's trying to say. But it was just this sort of black and white of like, no, you can only have this or this, rather than let's actually think about the word comfort and how does somebody define that word. And sort of what we struggle with on hospice is we throw that word around all, oh, we're here to make you comfortable. But what does that actually mean? Because that's going to look different for every single patient and family member that we see. And what makes somebody else comfortable might make us very uncomfortable. So I'm talking about that too. But it's just interesting to think about the language that we use, the medical terminology that we use, and sometimes just simple words that we use um, can really make a difference. So thinking about the words that we use, what is their supporter resiliency plan? You know, who's supporting them right there? And it could be people, it could be faith, it could be animals, it could be a number of things, nature. What's your support and resiliency plan as well as a healthcare team? And then how do we promote a sense of control or empowerment? You know, oftentimes people feel very unempowered within trauma, but then also being paired with a healthcare setting, sometimes they feel even less in control. And then again, recognizing your own trauma history and vicarious trauma. So as you sort of witness some of these experiences that you're seeing with patients and families, something that you may have witnessed in your own personal life, all that still stays with us. And so how you sort of recognize that. So you can see my full screen, right? Okay, because I see like, I have this box here and this box here. So I was just like, hopefully you can all see the whole screen. So I actually really liked this. I found this from this website, Echo, and basically, so how to support someone who's experienced trauma. So it has all these different pieces here. So, you know, the main heading, so space, you know, how do you allow time for somebody to calm down? It may take them longer to regulate their emotions and calm down, right? So how do we create space for that in an emergent situation that might be challenging? Predictability, right? Trauma survivors, not huge fans of surprises often. Recalibration, again, this talks about language that we use. You know, you're overreacting, don't be so oversensitive, or really using over anything. Try to eradicate that from your vocabulary. The other word that I would recommend sort of using sparingly is the word but, like B-U-T, not B-U-T-T. You can use the word B-U-T-T anytime you want in terms of talking about that. But B-U-T rather than and. So I'll talk about that when we talk about how to have some of these conversations. But see, it's very easy to use the word but. It negates everything that has come before it, right? So sort of thinking about that as a way to change the way we talk. So support, choice is really big. Reciprocity, give what you also need to receive, listening, empathy, empowerment. And then attribution, you know, referring to it actually as trauma, so putting that language to it. And then also perspective. So don't take responsibility for what's not yours, right? You know, because people can try and potentially, you know, put some things on you. So, and in the midst of it, it's very easy to sort of take it on of like, oh my gosh, this is a little bit overwhelming. So, you know, how do we also still have boundaries with compassion, right? So I just like this picture. Plus, it has lots of colors, so that always makes me happy, as you can see. I do like a fair amount of color. So the next thing I sort of want to move into is talking about how grief relates to trauma and what sort of end of life conversation or hospice or palliative care conversation would be complete without talking about grief and loss. So who doesn't like to talk about grief and loss? Everybody loves to, right? I'll talk about it all the time. That, funeral planning, uh, let's see, advanced directives. I am so popular at parties, you can't even imagine, right? So there's bound to be some grief when there's trauma involved. And oftentimes it's because they've had an experience where somebody may have died, or a relationship has died, or something that they were hoping for has died. There's a number of things that death can be involved in, not just the physical death of a person, but also the death of a number of things: death of function, death of a role in the family, appearance, all of those things. Those are all many losses, right? And if those happen in a traumatic way, you're going to see that sort of interconnection. So I like this as well. So this is also put together. I didn't come up with this. This is put together by another hospice, as you can see below. But it just sort of looks at the difference between a trauma response and a grief response. And again, somebody might be experiencing them at the same time. But this is sort of, I think, helpful to sort of think about that. Grief is not necessarily traumatic, but you might have some grief from a traumatic event. So thinking about that. And again, you sort of go down in terms of how to talk about it. The experience can be hard to talk about. Grief, oftentimes people can and want to talk about the loss, not always. Um, the sort of sense of feelings that are involved. How does anger come into play with that? How does guilt come into play with that? Um, and it's interesting to sort of think about this at this time of COVID, because I think this is really getting blurred for a lot of our families, um, as they are not able to be with a loved one while their loved one might be dying. And that can be very traumatic, and that can cause some complicated grief, right? Feeling disenfranchised, or you might hear the term ambiguous grief. So sort of ambiguous grief is something that people experience, for example, when somebody goes missing and the body's never found, right? Like you don't have an ability to sort of process that, um, because you don't exactly know what happened. And so similarly, if you're not able to be with your loved one at the end of life because of COVID, how do I know what their death was like? How do I know what their thoughts were? How do they know that I love them? All of these sorts of questions start coming up for people. So um, Jay says trauma for both the patient and family with the no visitors during COVID. Exactly. So I think for a lot of folks who are experiencing the death of their loved one now, and it may not even be from COVID, their loved one just may be dying. We have patients who are in nursing homes that don't have COVID in them because they don't let anybody in. And their loved ones are dying, but they can't come and see them. So it's going to be there's going to be a lot of complicated and complex grief happening in the next couple years just from that experience. So I think that's a really good example of how they can sort of be intertwined. And so, you know, the treatment, for lack of a better term, is going to look a little bit different for trauma than for grief. They might need some grief support, but they also might need some psychotherapy support, right? So who knows how that's going to be. So as we sort of think about this, as we start to have conversations with people, as you start to be, again, witness to this, it's going to start to impact you as well of, gosh, this really kind of sucks for a lot of people. And you might feel like you are part of that barrier for people coming in, because you're part of that system. So so sort of thinking about that and just realizing that yes, this is a job. Yes, we signed up for this. We didn't necessarily expect something like this to happen, right? So it can really be a wear and tear on us as professionals and as providers as well. So being gentle with ourselves and sort of acknowledging some of that also can be really helpful. And so I just sort of wanted to bring that up. But okay. So I'm not going to spend a lot of time on this because again, this will be available. I'll send it to you, Heather, so you can post it on Canvas or whatnot, and people can refer back to it as you need to or want to. So I want to ask this question to you guys. How do you know when someone's grieving? What does that look like? What what do you see when somebody's grieving? There are no wrong answers. Well, there might be some. Withdrawn, anxious, uh, very different from each individual, yes. Sadness, absolutely. Absolutely. Everyone grieves differently, yes. Anger, lashing out at others, yes. Denial. Oh, we'll talk about denial, Valerie. It's a trigger word for me. Potentially a lot of conversation about the person's situation causing the grief, absolutely. Yep, somebody's talking about it. Yes, lack of interest in normal activities that they enjoy, perfect. Withdrawal, yeah. Yeah, you guys are good. So normally I like to do things in person, right? We all like to do things in person. So I would be writing all of this up on a chalkboard or whiteboard or whatnot. Um, doing this very um, two column sort of thing. But I was gonna try and do it on the whiteboard here, and then I was like, let's not do that. Let's just pace ourselves in technology. Um, but so basically the reason that I asked that is indeed everybody grieves differently. So this is very, very, very basic grief theory, super basic. But two basic types of grievers, so intuitive and instrumental. So intuitive grievers are those folks who are cheerful, they're expressing their emotions, they're talking about it, they're talking about their loved one, um, having that emotional response, what we would call visual grief, that you can sort of see like, oh yes, this person is grieving. Versus instrumental grievers who are more sort of keeping it inside, very task focused. They might have more physical responses, so more fatigue or insomnia, changes in appetite, that sort of thing. So both can be viewed as not coping well by the other person. So imagine if there's a family member who is grieving as an intuitive griever in the family, and there's a family member who is grieving as an instrumental griever in the same family. You can imagine they may not see eye to eye on some things. It may cause some family dynamic issues um, or some family fights. Sometimes those are fun to observe, sometimes they're not. Um, but so this is just a way for you as clinicians to sort of help people start to understand the grief process. Because I believe a lot of folks in our society look at grief as that first column. And I have had a number of calls from other team members saying either two things. One, this person is crying, and I really think they need grief support. Okay. Tears and expression of tears are actually good and okay. And then I'll have folks from the team call me and say, this person is not grieving right. You know, they're in denial. They're keeping it inside. Okay. They're also planning the funeral. They are getting the house ready to sell. They are organizing a 5K to raise money for the disease that their loved one's dying from, right? So, we have to be able to bridge that gap within family members as we're seeing things. And as we're also sort of seeing folks who are going to be grieving differently. And how do we sort of normalize some of this for people? Because oftentimes people who are experiencing grief is similar to trauma, feel like they're the only ones that have ever gone through this, or that they're not doing it correctly. They're going crazy, um, or that they should be doing something differently. So one of our roles when somebody's experiencing something like this is to sort of normalize this. And so I think it's really helpful for us to understand this. I've had a number of conversations within families of, so it sounds like your brother is what we would call an instrumental griever. Let me talk to you about this. And they're like, oh, so he's not a jerk. He might be a jerk, but in this case, he's doing what he needs to be doing, right? So, and same thing of like, my mom is can't. She's crying all the time, and she, I don't think she can make any decisions right now. Blah blah blah. It's like, let's sort of think about this in a different way, right? Expression of grief doesn't mean that somebody is unable to be involved in a conversation. It just means that they need to express their grief in a different way, right? So, sort of understanding some of that can be helpful in terms of the work that we're doing. So here, the top ones aren't highlighted for any reason except that I pasted this into a different PowerPoint, and that's why. But physical, emotional, spiritual, and mental, right? So all of these things um, we can see as somebody's grieving. So some of the physical signs, right? These are things that you might be seeing as a healthcare provider that might cause you concern. Um, and then as you're sort of doing an assessment, you realize that there are other things going on for this person aside from potentially a cardiac issue. So it's also sort of recognizing that their grief and trauma might be impacting some of their physical symptoms as well. And then an emotional piece, which again is something I think we are a little bit more in tune with and comfortable with. Spiritual, and then mental as well. So we're thinking about that as we start to have conversations with people. So one of the things I just sort of wanted to mention, and I think Heather had wanted me to touch on this a little bit, is how does this look a little bit differently for folks who might have intellectual or developmental challenges, or I'm going to talk a little bit about children, and then also those cognitive challenges as well. So that could be dementia, that could be a TBI, that could be um, severe mental illness potentially. So sort of thinking about how grief is going to potentially look different and how we might support somebody a little bit differently in some of these categories. So, and you'll have family members asking you questions probably all the time about this, right? Like, I just don't know how to talk to my kids about what's going on. And you're like, oh, I don't know. Let's call the social worker, which is totally valid. You can totally do that. But I also want to give you some tools in your toolbox as well. A social worker may be out that day or may not want to talk with you that day because you didn't bring them the cookie that you promised that you bring them. Social workers always love good cookies. So for kids, the encouragement is you want to have open conversation and communication at a level that they can understand, right? It may not be, this person has an advanced cancer and it's doing this and this and this. It's this person's body is no longer working the way it's supposed to be working. Um, and this is what's probably going to happen to this person's body as they continue to go forward, and this is what it's going to look like. And really helping kids understand that, avoiding symbolic language of saying like, we lost mom today. Why aren't we looking for her? Right? Or grandpa went to sleep. So if I go to sleep, does that mean I'm not going to wake up? What is that? All these sorts of symbolic languages that we use. And oftentimes people want to protect the kids and they're like, well, we're not going to bring the kids in to see this person. Right? I cannot tell you how many adults I've met who are still pissed at their parents for not letting them come and see their beloved grandparents before they died. And still at age 50 something are still upset about that. So really saying it's okay for them to come in. You just want to prepare them for what they might see, right? If they're coming into an ICU, you want to prepare that kid of, this is what it's going to look like, this is what it's going to sound like, and this is what it's going to smell like, potentially. Not in a scary way, but just sort of saying, hey, grandma might have, it's going to have some tubes. She's not going to be able to respond to you. It doesn't mean you can't touch her hand, although in COVID, you might have to take one of those things. But just sort of preparing people and preparing kids to sort of understand what to expect. And they have the choice to come or not come, and they can change their mind at any time. Obviously, developmental ages, there's going to be some differences. And so, there's lots of information out there, but just sort of a general guideline. For folks with cognitive challenges, it's going to be challenging to engage them in some of those processes. They may not be able to come to the funeral, but how do you then bring the funeral to them at home? Can you create a shrine at home that they can sort of memorialize this person? What part can they play in this process? The other thing for folks with cognitive challenges is often it's the words aren't going to necessarily make sense for sort of that repetitive, like, well, where is this person? Where is this person? Where is this person? Can we tune into the emotion behind that of what sounds like you're really missing this person, or sounds like you really love this person? Let's look at photos and sort of try to engage in that way. And rather than trying to reorient that person constantly as like, remember they died, and sort of that re-traumatization over and over and over when they can't process that information. They know something's different, but how do they sort of engage at a different level versus words, looking more at engaging on that emotional level or connectedness level. So for folks with intellectual and developmental challenges, it's going to be fairly similar. And I hate to say this because I don't want to equate them to children, but it is sort of similar recommendation of open communication, providing choices, and providing a simple and concrete language, and involving folks in the process as best as they can be involved in. Right? So that's all I have to say on that. Okay. So before we go on to talking about you guys, because we have until 2:30, is that right? That's the end of class?
Yes.
Okay. I'm just trying to be aware of my time here. So one of the questions was, how do we sort of start conversations, or how do we deliver bad news? So I want to ask this question to you all. Why is it challenging to talk about death and dying in our community? What are the challenges?
I think trying not to upset or offend maybe the family members or the patient because it can be very stressful and it's a lot for everyone to deal with. And a lot of people aren't really ready or prepared for the inevitable. And so it's trying to find your words cautiously so that you can be informative, supportive, but not maybe overwhelming or scaring.
Yeah. Yeah, absolutely. What else? What else is challenging?
For me, talking about some of that stuff, not that I've had to have a lot of those conversations, but thinking about that, like, in what it would open up in myself, and like, would I be able to remain composed and professional enough to deliver this effectively for these people?
Also being able to appropriately address all the different cultures, because of course Washington State has a vast majority, like not majority, but different cultures. And it can be difficult in trying to, I guess, hone in on what is culturally acceptable and whatnot, just because there's a vast difference in so many different cultures here.
Absolutely. Absolutely. Anything else?
Maybe to add, this sounds kind of insensitive, but when you talk about it, you kind of know what's going to happen next, and they're going to need a lot of help, and there may be an emotional response that you're not prepared to deal with. And I apologize, like, about saying this sort of thing, but I don't know if I would be able to manage that, or even have the time, like, in my patient load, to be able to deal with the proverbial can of worms that I've opened.
Absolutely. Time is such a rare commodity in healthcare, right? And then, do I have the capacity or ability to be engaged with providing that emotional support to somebody, right? Is that really my role? Do I feel confident in that? Do I feel competent in that? Yeah, for sure. Yeah. Yeah. Okay. So,
oh, sorry.
Yeah, go for it.
I was just going to say, as healthcare providers too, kind of what Simeon was saying, we kind of know where the progression of disease is heading. And so it's hard not to bring our own biases when we're having that discussion, and kind of know where that road's going to lead. Okay. And let them make their own decisions is a challenge.
Yep. Yep. Absolutely. Yeah. So when we start to talk about, so we talk about this for our new hires in hospice all the time, because it's a big thing for us to have these conversations, which is interesting, because you would think by the time that people come to hospice, they would have had a lot of these conversations, but you might be surprised, or maybe you're not surprised, that indeed a lot of them haven't had these conversations. And we'll get patients who will say, well, the doctor just said I needed more help, and said that hospice could provide that. Okay, there's some missing pieces there. So how do we then start to have that conversation? So I basically sort of break it up into a few different things. So to start off with, I agree. Simeon, is that how you pronounce your name? Okay. Sometimes we don't have the luxury of being like, okay, I'm going to set aside this time. If we can, if we know it's super important, of like, I really have concerns that this person is not sort of understanding what's happening, I think maybe we need to set aside some time in a space outside of the room where the people need to be present and have an actual focused conversation. Sometimes we don't have that ability, but if we can sort of set that up, great. For home care, we want to make sure the distractions are reduced and that sort of thing, and turning the TV off and whatnot. So some of those things, or even in the hospital, obviously turning the TV off is a big thing too. It's like, how do we sort of reduce the distractions? But let's sort of break it down into 4 main compartments. And the first one being understanding. So for us in home care, we want to assess what somebody's understanding is of their disease. What has their doctor told them? and what's their understanding of hospice. Because oftentimes you'll have people who, and you'll probably experience this, you'll say the word hospice, and they'll be like, oh, no, 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 no. And it sort of oftentimes will shut down the conversation immediately because you're like, oh, I don't want to offend this person, or they're not ready to talk about this yet. I would challenge people to say, you want to be curious and you want to explore with them, you know, tell me what your understanding is of hospice, because they might actually have a very incorrect understanding of hospice, which is quite common. So whenever there's that sort of no, 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 it's turning that and being like curious of, help me understand, you know, what's going on with you? What has somebody told you about hospice? What's going on? That sort of thing. And for us, it's what's your understanding of your disease? What has your doctor told you? And sometimes, you know, you'll see it clearly documented in the note. Provided information on this, patient in denial. Now, did that person actually understand all of that information? That's a whole other thing. So rather than we focusing on tell, do you have any questions? We want to start with ask. You know, what's your understanding of what's going on? How do you like to receive information? Who needs to be here as you receive information? Now I'm going to tell you information based on what you just said. I'm going to pause. I'm going to respond to any emotion or let you have any emotion that you might have. And then I'm going to do that follow-up of, we've talked about a lot of things today. I just want to make sure that I was clear. Sometimes there's a lot of medical language. I want to make sure that I was clear. Can you just sort of summarize what we talked about today? So more of that ask, tell, ask, right? Because if you go in and shoot some information in somebody's face for a while, they're going to start shutting down. Or if you go in and say, you have a prognosis of 3 months or less, and then you continue to talk, I can guarantee you that person's not going to hear anything after you said you have 3 months or less to live. Right? So what do you want them to hear? How do you want to say it? That sort of thing. And then that follow-up of, did this make sense to you? Can you sort of summarize what we talked about? So that sort of idea of ask, I'll ask. What's their understanding of what's going on for them? So that's sort of the first piece of having difficult conversations. And obviously, we really seriously could talk about this for like a whole class period or a whole day. Honestly, there's lots of palliative care trainings that are whole day. So I'm breaking it down very, very sort of simply for you. And then the second piece is talking about hope. So when I hear the word denial, and I'm not, lots of people use the word denial. For me, I sort of translate that into hope or extreme hope. So what often happens for us is that a provider will give somebody bad news and then they'll say, you know, what are you hoping for? Usually won't use the word hoping, but I like to use the word hoping. So what are you hoping for? And then the patient will say, well, I'm hoping for a miracle, or I'm hoping for a cure. I'm hoping to get better, right? And immediately it's sort of like, oh, this person's in denial. They're not getting anything that we say, blah, 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 blah. I'm going to give them more information to try and hammer this into their head that, by the way, you're dying. All of those hopes that you're talking about are invalid. I'm going to challenge people to think about that a little bit differently. Think about for yourself, if you are diagnosed with a terminal disease, which hopefully none of you are, is it not a normal human nature response to think, I might be that 1% that beats this, or that 5% that lives 8 years and versus 8 months, right? So there's nothing wrong with that hope, but there's nothing that we can really do with it except hold it, right? So here's where that and versus but comes in. So if we say, it's our role to hold that hope with you, Yes, exactly. Motivational interviewing. Love motivational interviewing, Jay. Yes. It's human nature to want to survive. Absolutely. So it's our role to hold that hope with you because it is, as providers, it is our role to hold that hope. And it's my role to let you know about things that are causing me concern or that I'm concerned about. Is it okay if I share some of those concerns today? So you've done a few things, right? So you validated that hope because it's valid. You've said and, not but, because if you had used but, basically you've invalidated that hope. So and it is our role to let you know about things that cause us concern because that we are trained clinicians. That's our job. And then I'm going to ask you permission to share that. So I'm giving you control. I'm giving you some control that you don't feel like you have. When we talk about control and trauma-informed care and all that stuff, that loss of control, that the language that we use, how do we sort of give people as much control as we possibly can, knowing that some people are going to struggle with coming to terms with things, and that's okay. That's their journey. That's not our journey. How do we sort of separate the two? But if we're curious and we ask questions, I think that opens up a better conversation than me trying to give you information to convince you that I'm correct as a healthcare provider and you need to understand that this is what's happening. Even though that might be happening in our head of like, oh my gosh, this person doesn't get it. They might very well get it, but they might not want to talk about it. They're not ready to talk about it. Culturally, it may not be appropriate to talk about, as Jay was mentioning, right? Culture is the other piece that we'll talk about very briefly. Um, so sort of looking at hope in a different way. So what are you hoping for? I'm hoping to get better. I'm hoping to have a miracle. Great. What else are you hoping for? Well, I'm hoping to have my pain better managed. That we can do, right? I'm hoping to be able to get back home. I'm hoping to see my so-and-so graduate. I'm hoping, then we start to be able to create a plan of care based on hopes versus that hope, that first hope can't do anything about it. It's the same thing as when we say, do you want to be comfortable? Okay, now how do we define comfort? It's the same thing. How do we define hope? How do we define comfort? What does that mean to you as the patient? Because it's going to mean different things to everybody. So thinking about that in a different way and being curious, if somebody talks about a miracle, you want to explore with them. What is that miracle? Tell me what that miracle looks like to you, because we can't make an assumption either. So I love to tell this story, and I'm going to tell it. We have plenty of time. We had a nurse who worked in ICU before she came to hospice. She's retired now, but she told the story. There was a family with a young child who was on life support, who was not going to live, not going to make it. And so the medical team is talking to this family, and they're saying, this is what's going on. And the family just keeps saying, we're waiting for the miracle, we're waiting for the miracle, waiting for the miracle. And the medical team is getting highly anxious, as you can imagine. And so finally, our nurse, who wasn't our nurse at the time, but was working there, asked the mom, what does that miracle look like to you? And she said, we're waiting for the miracle of him to go to heaven. So, we can't ever make an assumption of what somebody's talking about when they're talking about a miracle or hope. We want to be very careful about making assumptions in those situations. And we want to be curious and say, tell me what that means. Help me understand what that means to you. The same thing if somebody says, I'm not ready for hospice. Okay. Can you tell me what it would look like when you are ready for hospice? What would that look like for you? Because you've done two things. One, you've opened up a conversation. And two, you've sort of forced them to start thinking about what will that look like? Or what do I assume hospice is? What is it going to look like? And now I basically have some roadmap of, okay, when we start to see these symptoms or whatever, remember, we had this conversation, we're seeing this. these are your parameters, not my parameters, right? You created these. Now we're going to talk about it in a different way. Um, so thinking about that, so understanding hope, grief, we've already talked about, and then culture is a huge piece of that as well. And I really want to say, for years we talked about being culturally competent. I hate that phrase, um, mostly because I don't feel competent in my own culture, let alone everybody else's. Right. So we are more moving towards the idea of cultural humility. I don't know if you've all heard that terminology. Hopefully you have. If you haven't, I encourage you to sort of look into this. But it's being curious again, because we're not going to know everybody's culture. And you could go and read a book about, oh, this is how, people in the Vietnamese culture view death. This is how people in the Hindu culture view death. You can absolutely do that. I can guarantee you, you're going to have many patients who do not fall into that category. And so rather than trying to be like, oh, I know exactly what this person is going to think, feel, or want, how are we more curious? So asking the question, what do we need to know as your healthcare team to provide care to you and your family? What do we need to know about you and your family? Right? That's a very open-ended question, but it's going to give you some good information. Or how has your family or how has your community provided care to folks who are seriously ill in the past? What does that look like? What rituals do we need to be aware of? So if somebody's going to die in your unit and you're not aware that there's going to be 30 people who are going to come and chant over this dead body for an hour, you might want to be prepared for that, right? So again, sort of thinking about some of those things. So that's sort of those 4 quadrants that I sort of look at. Obviously, it's a little bit more complex than that, but just those are hopefully some helpful questions to sort of how to explore some of those conversations. And it's not necessarily going to be your job to deliver that news. It really should be the provider who should be involved in that. Should being the operative word. Again, providers don't get a ton of education on how to have end-of-life conversations as well. I think that's changing. But, it's not something that like, we're going to teach you how to have an end-of-life conversation. It's more like, we're going to teach you this about the anatomy and that sort of thing. So it's kind of learn as you go, unless you're doing a palliative care rotation, and then you're going to learn a lot. But so oftentimes it's going to be a team effort, and sometimes you're just going to be planting seeds. And it may be that you have a conversation this week that's going to flourish into something next week, or it might be a month down the road, or it might be never, right? I mean, we can only do what we can do. So thinking about it in that way. Any questions about that? Okay. So I just want to sort of end or wrap up with acknowledging sort of the vulnerability that we also experience and the vicarious trauma that we experience as healthcare providers. And I know coming from a social worker, you're like, oh my gosh, enough woo-woo stuff. But it is important to sort of acknowledge the amount of trauma that we witness. And we cannot think that it's not going to impact us in some way. Because it is. It's going to look different for everybody, but it's going to impact us. So the idea of, there's compassion fatigue, and then there's also burnout. So, they go hand in hand. Sometimes one's on top of the other. Sometimes they're intertwined, right? So thinking about, that emotional strain, working with people who have some sort of trauma going on. So we've all probably experienced this. So I'm just going to ask this really, really quickly, but How do you feel when you're approaching burnout or compassion fatigue? What are some of your warning signs? What happens? What's going on for you? What are your symptoms? Come on, share it. Don't be afraid.
For me, at least, it's when I get asked to pick up a shift, I'm like, yeah, no, I'm less likely to want to go to work, do things to be like, nope, unwilling, do not want it,
Yep,
ask someone else.
yep, absolutely. And I see, so Mariah says agitated, less ability to deal with others. Valerie complaining more about work. Kirsten says less motivation at home in my personal life. Frustration, snap at people from Megan. Yeah, absolutely. Yeah, perfect. So does this look familiar? We just saw this a few slides ago. So if you actually think of the responses that you normally feel and most people feel in terms of what we would call compassion fatigue or burnout, they are very, very similar to signs and symptoms of grief. So when we are talking about compassion fatigue, what we're really talking about is professional grief. How do we as professionals grieve? Right? What does that look like for us? And how do we sort of acknowledge that we are human beings? So I love this quote. It's by Rachel Naomi Remen. So the expectation that we can be immersed in suffering and loss daily and not be touched by it is as unrealistic as expecting to be able to walk through water without getting wet. This sort of denial is no small matter. The way we deal with loss shapes our capacity to be present to life more than anything else. The way we protect ourselves from loss may be the way in which we distance ourselves from life and help. We burn out not because we don't care, but because we don't grieve. We burn out because we've allowed our hearts to become so filled with loss that we have no room left to care. We come to healthcare because we want to help, we want to make a difference. Generally, I'm generalizing. And then it's sort of, we start to get filled up. So, and then we burn out and we're like, well, I'm just going to leave. I'm going to leave this job, or I'm going to leave this, blah, blah, blah. And it's not that you don't care. It's just that there's so much going on that sometimes it becomes hard to sort of process that withdrawal from our patients. Yeah. So sort of start to think about this, how do I cope in times of stress? What works well, what does not work well? Eating an entire chocolate cake might sound like a good idea at the time. How you feel the next day might be different. So the other thing to think about is the word self-care, and what does it mean to me? So you'll have people talk to you about self-care all the time. Oh, you need to do self-care. You can Google self-care, and there'll be lists of take a walk, take a vacation, do this, take a bath, blah, 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 blah. And I've heard so many people say, I don't have time for self-care during the day. I'm running around. I barely have time to go to the bathroom, right? We've all been there. So that, again, it's reframing how we think about self-care of what can I do when I have 30 seconds? What can I do when I have a minute, 5 minutes, a half day, a whole day, right? Rather than thinking about, oh, I'm going to have to leave the unit and take a walk somewhere, is a deep breath sufficient? There are 2 deep breaths sufficient. Whatever that might be, can I lock my, so I worked very briefly in an acute care setting, and I had to I'm going to the bathroom. I don't have to go to the bathroom, but I'm going to go to the bathroom. I'm going to sit down and just nobody can find me, right? See, some people are relating to this, but right. So how do I redefine self-care, and how do I do it in the midst of sometimes craziness? So it might be just a mantra, right? So here are all sorts of examples. So these are all hospice examples from clinicians that they've developed over the years. So as we're in that situation, it's like, okay, I just got to repeat this over and over and over again. You know what? This is not my family. I am not here to fix this. family, this family dynamic, right? I could easily get sucked in. It's so easy to get sucked in, right? I can be compassionate. Doesn't mean I'm not compassionate, but am I going to actually fix this? Maybe not, right? And then how do we reconnect with our work? You know, sometimes it's very hard to think about this and you're like, I really would rather wish I would work in like a coffee shop as a barista, right? Does anybody have that sort of fantasy sometimes of like, I just go to work. I could be a greeter at Walmart. Everybody's happy to see a greeter at Walmart, right? I don't have to do anything except say hi to people all day. Um, so, but there was a reason that you wanted to work in healthcare. There may be a story, there may be a person, whatever that inspiration was. So what inspired you, and then what continues to inspire you in your work? So I said I worked very briefly at an acute care setting, and it was UW Medical Center. But they did a survey of the oncology ICU nurses there, and they asked them, what percentage of patients do you think die on the oncology ICU? And they were like 75%, 85%, 90%, very, very, very high numbers. This is what the response was. And the actual data and statistics was like 18%. So what was happening is that they were sort of looking at all of these, what they would consider horrible deaths of these patients. And that's what they were sort of taking with them, rather than all these other experiences that they were having there, of families that they were helping. It doesn't mean that the patient actually survived completely, but it didn't die there. They might have gone home, they may have gone to another unit, whatever that might be. But just sort of realizing like, you're going to have days when it's sort of like, oh my gosh, is anything going right? It just feels like I'm overwhelmed. Why do I do this work? And like, not asking in the way of like, why do I do this work? But more like, why do I do this work? There's a reason. Let me connect with that. Let me connect with some of my positive experiences of what brought me to this point, right? And it's hard. I'm not saying it's going to be easy, but it's sometimes very easy to lose sight of that. So in the summary, right, be aware of your own loss history. You do want to maintain appropriate boundaries. Identify your support system, self-care, and then reconnect with your work. And I'm so sorry that I did not realize that I would talk for this long. But here are some resources and tools. I would recommend everybody to read the book Trauma Stewardship if you haven't. It's super helpful. There's also a website towards trauma stewardship. And then here's that link for that transgender healthcare stories from the Oregonian as well. So we don't have any time. I mean, I'm fine if people have questions. I know that your class is over, and I'm so sorry, Heather. I know you wanted me to leave time.
Let's open it up and have a time of questions if people can stay longer. And feel free for those that need to move on. But I just want to give space for those that may want to chat more and have questions.
I had not heard of the cultural
Humility.
And so can you tell me a little bit more about how to approach taking on that skill set?
Sure. There's a really great picture that I can send along to Heather as well that sort of talks about it's just a different model that somebody created called the Humble model, HUMBLE. So they did this research, but basically the concept is you want to be curious. So you want to be curious about that person's culture, what's their background, ask questions, but you also really want to be curious about your own background and what you're bringing to the table. Because again, particularly, and all of this is through the lens of end of life for me, sorry. But we all have our own thoughts, ideas, beliefs about what end of life should look like. And if a patient is choosing something that does not match that, it can be really hard for us to step back and be like, whoa, okay, is that a bad choice or is that just their choice? And how does that make me feel? And is that because of my stuff? Right. So it's sort of being aware of being curious about their culture and what's important to them and what brings meaning. And we talk about, I like to talk about the word meaning more than culture. You know, what is meaningful for people? What does meaning bring? And then conversely, why am I struggling with this so much? Because clearly I have some thoughts and beliefs around what this is. And I'm totally looking at you on the screen. And I realize that I'm probably looking to the side and it looks like crazy, like a
This
crazy
is
person.
like so valuable to me. Yeah, I appreciate that.
Yeah. Any other questions? I'm happy to come back too.